बिस्मिल्लाहिर्रहमानिर्रहीम रब्बि इश्रह ली सदरी व यस्सिर ली अमरी वहलुल उक़दतम मिन लिसानी यफ़क़हू क़ौली. First of all, I am thankful to my friend Dr. Guido Siriboti for inviting me here to deliver this lecture in this seminar, and I am thankful to all of you and especially the organizing committee for arranging such a good seminar here in Lugano in Switzerland. I am going to talk about renal artery ultrasound, and I am Dr. Saeed Ahmed Gilani. I work as a director for the Middle East branch of Jefferson Research and Education Institute, Philadelphia, USA. The first thing is renovascular hypertension. It can be due to renal artery stenosis, and renal artery stenosis can result due to atherosclerosis, fibromuscular dysplasia. And the other causes are embolization, renal artery aneurysm, aortic correction, arthritis, dissection, congenital neurofibromatosis, and irradiation. The other cause of renovascular hypertension is renal parenchymal disease. Here you can see the anatomy. Just going to the basics, this is main renal artery. Then we have segmental arteries and interlobar arteries. These are arcuate arteries. There are a few technical difficulties in scanning renal artery, like depth of arteries due to obesity, overlying bowel loops, or due to difficulty in respiration, or the patient is not cooperative. This needs patient's cooperation. Then comes anatomical variations like multiple renal arteries, proximal subdivision, or position and course of the vessels. The other causes of the technical difficulties can be previous surgery or operating skills. 12 hours overnight fasting is usually recommended, or we can give some fluid load along with this fasting. It is preferred to have morning examination. 3 to 3.5 megahertz transducers are used, and we need high quality color Doppler ultrasound. Optimized parameters include minimum color box size and minimum B mode depth. Let's have an overview of techniques. We scan aorta, obtain Doppler signals from both renal arteries from origin, proximal, mid and distal. Then obtain intrarenal waveforms, mid, third, upper and lower poles. Perform B mode of both kidneys. Then while the patient is lying supine, scan aorta longitudinally, obtain Doppler trace for peak systolic velocity, and transversely locate left renal vein, locate renal arteries, obtain Doppler traces origin to as far distally as possible. The normal waveform will have low resistive, there will be continuous diastolic flow, and spectral broadening is common. Use graded compression to displace bowel gases. You can see both kidneys, and then we have renal artery and vein. This is IVC and abdominal aorta, and we can see the renal vessels. We can assess abdominal aorta and the spectral flow at IVC. While the patient is lying obliquely, approach artery from lateral aspect. This is lateral to anterolateral for right kidney. So if this is the anterior abdominal wall, we start scanning from here, and from lateral to anterolateral we move our probe in this direction. And for the left kidney, lateral to posterolateral for left kidney. This is lateral to posterolateral, going to the back side towards the spine towards the vertebrae. Intrarenal waveform, segmental artery or interlobar artery waveform should be taken from upper, mid and lower parts of the vessels. Both kidneys examined on B mode for size and parenchymal characteristics. For renal artery, the stenosis, if it is more than 60%, it is very important. Peak systolic velocity is measured, renal aortic ratio is measured, acceleration time and acceleration index are very important. First of all is renal aortic ratio, which is measured by dividing renal artery peak systolic velocity divided by aortic peak systolic velocity. And if the renal aortic ratio is more than 3.5, it is showing significant stenosis. Then comes renal artery. For the renal artery stenosis, we measure acceleration time and acceleration index, and we look for the graph. This is velocity versus time, and this is the area which is measured for acceleration time. And usually the acceleration time is less than 0.07 seconds in normal. Then we measure acceleration index. It is measured by dividing systolic velocity with acceleration time, and this is the area which is measured. This is systolic velocity and it is acceleration time. We divide this systolic velocity with the acceleration time to get acceleration index. And acceleration index is usually more than or equal to 3 meters per second square in normal, and use a fast sweep time for this assessment. Resistance to blood flow through the kidney is very important, indicates parenchymal disease. For this we measure resistive index, diastolic versus systolic ratio and systolic versus diastolic ratio. The resistive index is measured by using this equation: velocity, peak systolic velocity minus end diastolic velocity divided by peak systolic velocity. It will give us resistive index, and it is usually less than or equal to 0.7, which is normal. It means if it is more than 0.7, it will be abnormal. Then coming to the resistance to blood flow through the kidney, which is measured in the segmental or interlobar arteries, diastolic versus systolic ratio is equal to end diastolic velocity divided by peak systolic velocity, and this diastolic versus systolic ratio is more than or equal to 0.2, which is normal. The parenchymal resistance, other uses are pilocalectasis, which indicates obstruction. It means this is the point, 0.7 is the point. If it is less than 0.5, there will be non-obstructed. If this resistance, parenchymal resistance, is more than 0.7, it means obstruction in the vessel. Then comes stent patency, confirm normal outflow and distal end, and check renal perfusion. For transplant diagnosis, we measure resistive index. Resistive index increases as rejection occurs, and acceleration time increases with the proximal renal artery stenosis. For renal vasculature, we have to remember some points. Single renal arteries to kidneys occur in about 2 to 3 times. Unilateral multiple renal arteries in 32%. Bilateral multiple renal arteries in 12%. Multiple renal arteries entering the hilus are of equal caliber. Accessory renal arteries to poles are smaller than hilar renal arteries. Multiple right renal veins occur in 28%. Retroaortic left renal vein occurs in 3%. Circumaortic renal vein occurs in as many as 17%, and horseshoe kidneys occur in approximately 1 per 500 to 700. Here we can see angiogram along with ultrasonogram. This is aorta and right renal artery and left renal artery. Here we can see the main renal artery and accessory artery, which was confirmed on the angiogram, on the retrogram. There is again another angiogram showing the accessory renal arteries along with right and left renal arteries. So the consequence of renal artery disease includes renovascular hypertension, renal failure, proximal episodic pulmonary edema, which is called flash pulmonary edema, rupture or embolization from renal artery aneurysm. Hypertension essential is usually 90 to 95% and secondary is 5 to 10%. Secondary causes of hypertension are renovascular, renal parenchymal disease, renin secreting tumors, correction of aorta, endocrine causes, pregnancy, renal transplantation, drug therapy and drug abuse, and neurologic disorders. The renovascular hypertension is 5 to 10% of hypertension patients. Usually severe hypertension is seen. It involves younger patients. It has shorter duration, difficult to control. Epigastric bruit is seen in some patients of this renovascular hypertension, and atherosclerotic changes can be seen elsewhere. Renal artery pathology includes atherosclerosis, fibromuscular dysplasia, and other pathologies like vasculitis, dissection, trauma, correction of aorta, and neurofibromatosis. Here we have stenosis of the renal vessels. You can see that this is abdominal aorta, and this was the vessel which was removed. Atherosclerotic renal artery disease has following characteristics. It dominates in more elderly male than females. Standard risk factors and disease in other adults, usually ostial or in the adjacent proximal artery. Lesions are usually eccentric. Disease is frequently bilateral, may be associated with superimposed thrombosis, dissection, embolization, or aneurysm of the renal artery. Abdominal aortic aneurysms are often associated with uni or bilateral renal artery stenosis. Here we have tortuous renal vessels. The fibromuscular dysplasia, it is of intimal origin. The percentage is 1 to 2%. The medial origin are 95%, which can be medial fibroplasia, perimedial fibroplasia, and medial hyperplasia. The periadventitia is 1 to 2%, again according to Harrison's book published in 1971. Fibromuscular dysplasias have following characteristics. Non-inflammatory vascular disease primarily involves